As we've heard today, one of the most feared consequences of fatty liver disease, as well as hepatitis C, and for that matter, hepatitis B, is the development of hepatocellular cancer. To discuss this topic, it's a pleasure to welcome to the podium Dr. Vatche Agopian. Dr. Agopian is an assistant professor of surgery at UCLA, focusing on liver transplantation and hepatobiliary surgery. Dr. Agopian.
Good morning, everybody. There we go. Okay, great. Thank you. So I appreciate the opportunity to be here. I'm going to speak about hepatocellular carcinoma, but I also want to take this opportunity just to kind of give you guys a current update about where we are in the current management of not only primary liver malignancies, which I'll talk about, but also some of the secondary liver malignancies. So in the ambitious next 40 minutes or so, I'll basically briefly discuss the surgical evaluation of patients for resection, and then focus the rest of the topic on the primary liver malignancies, which arise from the cellular elements of the liver itself, and the secondary liver malignancies, which represent metastases to the liver from extrahepatic primaries. Now, the most common primary liver malignancy by far is hepatocellular carcinoma, probably greater than 90%, and these arise from the hepatocytes, the majority of patients who have underlying liver disease or cirrhosis, and a far second is cholangiocarcinoma, where you have cancer arising from the biliary epithelium within the liver. For metastatic disease, we'll focus on colorectal hepatic metastasis and neuroendocrine liver metastasis, for which there really is a clear role for surgery, and consideration of resection of non-colorectal, non-neuroendocrine metastases is really warranted on a case-by-case basis. It's not accepted widely, and we're not going to focus on that today. So it hasn't been until the last several decades where major liver resection has been part of the routine armamentarium of surgeons. As recently as the 1960s and 70s, the results from liver surgery were really quite morbid, with high rates of morbidity and mortality that left something to be desired. Well, what's changed now? Hospital mortality is now well less than 5%, and a lot of these advances have come because of a better understanding of the basic principles of liver surgery. This includes better anesthetic management with low CVP surgery, better perioperative care, improved techniques and innovative energy devices that make the operations more safe with less blood loss, and finally, the significant improvements of the medical therapy of patients with liver malignancy has allowed for surgery to provide a benefit to an increasing number of these patients. I'm not going to focus on the operations too much, but suffice it to say that patients with any liver malignancy usually require large resections, and these can be non-anatomic resections, such as a wedge resection or segmentectomy, or anatomic resections based on the vascular inflow and outflow of the liver that include a right hepatic lobectomy or a left hepatic lobectomy, an extended right, where we say we take the medial portion of the left lobe along with the right, or an extended left hepatic lobectomy, where we take the medial portion of the right lobe, and in rare cases, we can do a central, or what's called a mesohepatectomy, where we resect the median portion of both sides of the liver. So for patients to be considered for liver resection, the resection itself needs to be anatomically feasible, and the patient needs to be medically fit with no prohibitive cardiopulmonary comorbidities or the presence of any significant underlying fatty liver disease. And what we use to assess that is, again, a patient's serum bilirubin, platelet count, and the presence or absence of ascites. As Dr. Durazo mentioned, the epidemics of diabetes, obesity, and the metabolic syndrome has really led to an explosion of non-alcoholic fatty liver disease and its progressive form, non-alcoholic steatohepatitis, that can really limit the ability of the liver to recover after a major operation. A close relative of NASH is what's known as CASH, or chemotherapy-associated steatohepatitis, and this is certainly a consideration for us for anybody who's had any significant amounts of chemotherapy prior to consideration of surgical resection. Finally, no major operation should even be considered without taking into consideration both the size and the quality of the future liver remnant. So what is the future liver remnant? It's basically the ratio of the volume of the liver that we're to leave behind to the total liver volume, and this really needs interpretation in the context of one's underlying liver function. So while most people would accept an absolute minimum cutoff of 20%, below which there is a significantly increased risk of death and or liver failure. We really don't currently have any guidelines on what the minimal amount of liver we can leave behind for patients who may have underlying liver disease. And in these circumstances, basically we would usually recommend a 30 to 40% future liver remnant to allow for a safe resection. So how do we assess the future liver remnant and what can we do about it? I'll just briefly tell you where we are now. We use a volumetric CT or MRI. These are contrast-enhanced imaging studies where we manually outline the different liver margins on multiple slices, and a software integrates between these to give us the volumes of interest. We can see how much the tumor is in terms of the whole relation of the total liver and how much we're going to take out and how much is going to stay behind. And in cases where the liver resection can actually be limited by our concerns about not having enough adequate liver remnant volume, we can actually employ preoperative portal vein embolization with our interventional radiology colleagues, which allows for the redirection of nutrient-rich blood towards the side of the liver that we want to stay, allowing for its growth and potentially enabling resection. So very quickly, portal vein embolization is performed with a percutaneous access of the peripheral portal vein, and particles and coils are used to block off the portal vein branches on the side of the liver that's actually going to go, that allows the nutrient-rich blood to essentially go into the future liver remnant, allowing for hypertrophy. This is a very well-tolerated procedure with pretty good results. It can increase the volume of the future liver remnant 60 to 90% in non-cirrhotics, with a more modest increase in patients with underlying liver function. Occasionally, we may run into trouble with liver insufficiency or considerations of tumor growth or spread while we're waiting for the hypertrophy to occur, but nonetheless, it allows us to proceed with safe resection. So I'm going to focus now on the most common primary liver malignancy, which is hepatocellular carcinoma. I'm going to start with a case. This is a patient of mine, is a 54-year-old gentleman with obesity, known hepatitis C viral infection, who underwent a screening ultrasound. He was found to have a mass. His AFP was elevated to 20, and this was followed up by a contrast-enhanced imaging study, an MRI, that showed a 2-centimeter arterially enhancing mass in the left lobe of the liver. His platelet count was 150, and the rest of his liver function tests were really pristine. Here you can see this is his contrast-enhanced MRI. You can see the contrast in the aorta. This right here is his liver, which is cirrhotic, but not very cirrhotic. This right over here is the mass, and it's arterially enhancing, meaning it's taking up the contrast. And on portal venous phase, when we wait a little bit later and scan the patient again when the blood is running through the portal circulation, you can see it washes out. So hepatocellular carcinoma is actually quite unique in this respect, because it's really one of the only cancers that I can think of that in the right background, for patients who have cirrhosis, the imaging characteristics themselves can actually be diagnostic. So if you have this late arterially enhancing lesion with portal venous washout in a patient who we know has cirrhosis, we don't need to biopsy those lesions. Okay, so this is diagnostic for hepatocellular carcinoma, even if the AFP is not elevated. So a word about hepatocellular carcinoma. It's a common cancer worldwide, not as much in the United States, but we're getting there. About 1 million new cases per year. It's a highly lethal malignancy with a median survival of only about 6 months if it's left untreated. There's about 25,000 deaths per year attributable to hepatocellular carcinoma in the United States. And as we had mentioned, the majority of these deaths are occurring in patients who have underlying cirrhosis, which is the major risk factor for the development. This slide over here shows the rising incidence of hepatocellular carcinoma in the United States. Shown in the orange bars, you can see nearly a 5-fold increase in the incidence from the early 1970s to the late 2000s over there. And this is probably attributable to the peak in the hepatitis C epidemic, and what's coming now is the epidemic of fatty liver disease and NASH. So the risk factors for hepatocellular carcinoma, well, basically anybody who has underlying liver disease and definitely cirrhosis needs to be screened and is at risk for developing this. This includes patients with hepatitis B, C, alcoholic liver disease, hemochromatosis. And what's really been alarming, actually, is that in NASH patients, there are now reports that not only do they develop liver cancer when they're cirrhotic, but we're actually even picking up cancers in patients that don't have full-blown bridging fibrosis and cirrhosis. Even in the early fibrosis stages, we're actually picking up some cancers in these NASH patients, which is really problematic. Other associated factors, Not surprisingly, are the things that are associated with fatty liver disease, diabetes, obesity, the metabolic syndrome. Cigarette smoking has been linked. Oral contraceptives have been linked to the development of hepatocellular carcinoma. This is usually due to the development of an adenoma or an enlargement of a hepatic adenoma that can then degenerate into a malignancy, and some toxin exposures. So what are our imaging options? As Dr. Durazo had mentioned, anybody who we suspect has any chronic liver disease should undergo an ultrasound and screening AFPs every 6 months at the very least, if not every 3 months. And usually what ends up happening is we pick up a mass on the ultrasound in the liver, and then this is followed up by the more diagnostic and definitive study, which is a contrast-enhanced axial imaging study, either a CT scan or an MRI with contrast, that demonstrates the characteristics that I spoke about, that the lesion lights up on the arterial phase, it washes out on the portal venous phase, and 80% of the time, the HCCs are going to have these characteristics, and you're not going to need to pursue it with any further biopsies. So one of the curative modalities for patients with hepatocellular carcinoma is surgical resection. However, as we mentioned, since the majority of these patients have underlying cirrhosis, that can certainly be challenging. For any cirrhotic patient to even be considered for resection, we would require that their platelet count be at least 100,000. They should have normal serum bilirubin with no ascites, minimal or no portal hypertension, and really a limited number of lesions in one side of the liver. Basically, we're looking at Child's A cirrhotics to even consider them for surgical resection. And why is this? Well, this is based on very good data, which is now maybe about several decades old, but really stands the test of time, that patients who undergo surgical resection for hepatocellular carcinoma have an excellent 1 in 5 year survival if they have no portal hypertension and normal bilirubin. But for patients who have maybe more advanced stages with some portal hypertension or high bilirubins going in, their 5 year survival is only 25%, and they're not served well with surgical resection. So getting back to the case that I described, this is a gentleman that was a Child's Class A cirrhotic, and so we basically recommended to him that we may be able to resect this lesion. This is a laparoscopic view over here that you can see. The background of the liver is cirrhotic. You can see it's bumpy. This is the falciform ligament. This is kind of the lesion right here bumping up from the surface. We basically score the liver with some energy devices called the harmonic scalpel. You get under the lesion, and here's the resection bed with the entire lesion resected. That's the falciform ligament going down to the left portal vein. This is the resected specimen with the falciform ligament right down here. This is the lesion. Bivalve, you have a 2 centimeter hepatocellular carcinoma with margins. Unfortunately, as many of you know, hepatocellular carcinoma is a disease that usually occurs in the field defect of a bad liver, cirrhotic liver. So having said that, a lot of these patients have multifocal disease, or they have decompensated liver disease with portal hypertension and cirrhosis, and they're not candidates for resection. And so in these circumstances, the rationale for liver transplantation is that it not only provides the best oncologic resection, you're removing everything with no chance of leaving anything behind, but it also treats the underlying cirrhosis as well as restoring normal hepatic function. However, the early results with liver transplantation for hepatocellular carcinoma were really quite dismal, with really high rates of recurrence and very low long-term survival, and this is probably because we didn't have a good understanding of who would be and wouldn't be a good candidate for transplant based on their tumor characteristics. It wasn't until 1996 when Mazzaferro from Italy published a now landmark article in the New England Journal of Medicine describing what is now very widely known as the Milan criteria, namely, if you have one tumor that's up to 5 centimeters in size, or up to 3 tumors, no one tumor greater than 3 centimeters in size, that you have an excellent 4-year survival of 85% with only an 8% recurrence risk at 4 years. This Milan criteria has stood the test of time. It's been validated over and over and over again with multiple other prospective series, and is now widely accepted as the standard for donor liver allocation for patients with hepatocellular carcinoma. Now, since the Milan criteria were initially proposed, there have been multiple other iterations of criteria, kind of, messing with the sizes, et cetera, et cetera. This is really all in an effort to increase the number of patients that can benefit from liver transplantation. Probably the most Popular of these criteria are the UCSF criteria, which posits that one tumor can be up to 6.5 centimeters in size, or you can have up to 3 tumors with no one tumor being greater than 4.5 centimeters in size. And at least in their original publication about a decade ago, for patients who were within the UCSF criteria, they showed an excellent 1 in 5 year recurrence-free survival, 90 and 75%. However, for patients who were outside these criteria, had more advanced tumors, they did not do well with liver transplantation, as you can see. So we recently looked at our own UCLA experience and published this. This is the largest reported single institution experience of liver transplantation really in the world from a single institution. And we showed a 5-year overall and recurrence-free survival of 60 and 56%. And that's actually pretty good considering we included in our cohort a lot of the patients transplanted from the 80s and 90s when we didn't have all these criteria that helped us select the patients. When we broke them down further, again, we showed the same thing that's been shown over and over again. If you're within the Milan criteria or outside the Milan criteria, but with some treatment have been downstaged to within those size criteria, that you do quite well. And for patients who continue to remain outside these criteria, had the larger tumors, they didn't do well. Again, we confirmed that. And we also did a multivariate analysis looking at what predicts whether patients recur their cancer after liver transplantation for hepatocellular carcinoma. And not surprisingly, like any other solid cancers, the things that mattered are the nuclear grade or differentiation, the presence or absence of vascular invasion, the radiologic criteria, and some serum biomarkers, the neutrophil lymphocyte ratio, which is now being recognized as an important systemic inflammatory marker that predicts cancer recurrence in a whole host of cancers, serum alpha-fetoprotein, and the cholesterol. So for patients who may not be candidates for surgical therapy, whether it be liver resection or liver transplantation, the interventional radiology-directed local regional therapies have really become an invaluable tool to treat these patients. I'm not sure why this came down here, but these include the transarterial therapies, including transarterial chemoembolization or transarterial radioembolization with radioactive particles, Y90, or the ablative strategies, which include radiofrequency and microwave ablation, thermal ablation, or percutaneous ethanol injection. And while taken collectively, most people don't think that these are curative treatments in themselves. They really can have a significant impact. Here you see a hyper-enhancing lesion that's treated with TACE and it's completely dead. Same with this smaller lesion that's treated with microwave ablation and is completely necrotic. So the role for these adjunctive local regional therapies now are to help patients who are not initially candidates for curative surgical therapy, to basically bring them within those criteria, or if we can't do that, you can potentially improve their long-term survival. So I'm going to move on now and talk about the second most common primary liver malignancy, or what we call cholangiocarcinoma. This is, like I mentioned, much rarer. I'll start with a case. This is a 51-year-old female with hypertension, diabetes, who presented with some elevated liver function tests and jaundice. She had an elevated CA19-9 of 310. She was worked up with a contrast-enhanced CT scan and MRI that showed the presence of a hilar mass with proximal bile duct dilatation. She underwent an ERCP with a stent and brushings that revealed some atypical cells. So here's her scan. This is a contrast-enhanced CT scan. You can see the contrast in the aorta. This is here the liver, right and left-sided biliary dilatation. And if I can show you, this is, again, all this dilated bile duct. As we come to the area of the common hepatic duct, you see the soft tissue thickening around the bile duct, and finally occlusion of the bile duct right here in the mid-porta. And then you can see here on the MRCP, this is right and left-sided biliary dilatation, and this void over here with the MRI is telling you where the tumor is. That's where you don't see the contrast anymore. So that abrupt cutoff over here is where you can kind of get a sense of where this mass is with a distal, normal-appearing common bile duct. So a word about cholangiocarcinoma. It is a cancer arising from the biliary epithelial cells with an incidence of 1 to 2 per 100,000. Risk factors for development of cholangiocarcinoma include primary sclerosing cholangitis, patients with choledochal cysts, patients with common duct stones. Parasites can do it, but not so much. We don't see that in this country so much. And what's been alarming, again, is we're seeing more and more both intrahepatic and extrahepatic cholangiocarcinomas in patients who have significant underlying chronic liver disease or diabetes, obesity, and the metabolic syndrome. Anatomically, cholangiocarcinomas can be further classified as intrahepatic, which arise from the bile duct epithelium within the liver itself. Hilar, or what's known as the Klatskin's tumors, arise from the bifurcation of the bile ducts, and the distal cholangiocarcinomas arising from the further areas of the bile duct as it enters the pancreas and duodenum. For the purposes of this presentation, I'm just going to focus on the intrahepatic and hilar as it pertains to the liver, and the distal cholangiocarcinomas often require pancreatic duodenectomy or the Whipple procedure for treatment. The hilar lesions can be further subclassified with the bismuth classification. Not anyone ever remembers these, but I'm just showing them to you because they basically have an implication about how we treat these patients. The type 1 bismuth lesions involve the common hepatic duct just below the confluence, with the type 2 lesions involving the bifurcation of both the right and left duct. These patients will require a radical bile duct resection cutting out this entire area, with basically a piece of intestine being brought up and sewn to the bile ducts. Type 3 lesions not only include the common hepatic duct, but extend up one side or the other, either the right or the left. And in addition to just cutting out the bile duct, a lot of times what we have to do for these patients is cut out that entire side of the liver, because at this point already this cancer is already heading into the liver substance, and there's really no way to get a negative margin resection without taking out that side of the liver. And finally, the type 4 lesions are really unresectable. They involve the entire common duct, both the right and the left, as well as the secondary biliary radicals. So although there are multiple modalities that may aid in the diagnosis of cholangiocarcinoma, and I've listed them here, ultrasounds and CAT scans, MRs, ERCPs, we have endoscopic ultrasounds, intraductal ultrasounds, we use PET scans. The problem is diagnosing it is really quite challenging. And the reason this is that the majority of patients, unfortunately, have very nonspecific, vague symptoms until the biliary obstruction sets in. Once the bile duct obstruction sets in, then they're jaundiced, but usually this is a very busy area. You can imagine, there's a bile duct, the blood vessels, everything around, so by the time the whole bile duct is obstructed, it's usually involving something or another, a blood vessel, and it becomes very difficult. And for the greater than 50% of patients who are unresectable at the time of their diagnosis, their prognosis is really quite grim. So what do we use as criteria for determining, well, can we or can't we cut these tumors out? Of course, they got to be medically fit. We rule out metastatic disease, and these include lymph node involvement outside the immediate area, retropancreatic nodes, celiac nodes, any discontiguous liver metastases or systemic metastases. I just mentioned this, but involvement of the main hepatic artery or the portal vein was traditionally absolute contraindication. Nobody would even think about it. Now there are some series in very well-selected patients where they resect the blood vessels and reconstruct them with some reasonable results, but this is not mainstream yet. Basically, to be considered resectable, you need to have one side of your liver that's not atrophic and have its branches of the hepatic artery, portal vein, and bile ducts completely uninvolved. So what are the prognostic factors for how patients do after resection of cholangiocarcinoma? Lymph node involvement and the presence of vascular invasion, like many other solid cancers, bode very poorly for these patients. And multiple studies have really borne out the very important critical role of an R0 resection, or that's a term we use to say it's got to be a microscopically margin-negative resection. We can't leave any cells behind. There is no rule for tumor debulking or palliative resection in this disease process, and as you can see over here with many studies that show this exact same graph with really quite dismal long-term survival if you've resected a patient and microscopically left cancer cells behind. You do no benefit for the patient. So getting back to our patient, we took her to the operating room, and I'll orient you here. This is the bile duct is missing, so here's the trifurcation of the bile duct. We have to go all the way up. This is the right branch to the segment 4 over here, and the left-sided bile duct. The entire bile duct was resected. All the arterial branches are skeletonized. All that lymphatic tissue is taken. The portal vein over here you can see is completely skeletonized, completing that lymphadenectomy that helps us in staging these patients. And the bile duct's reconstructed with a piece of intestine. Here's her gross. You can see this is the bile duct lumen with this thickening, and this is part of the problem with cholangiocarcinoma, as I mentioned, is that a lot of times the tumors don't grow into the lumen per se. You get all this soft tissue thickening around the lumen that not only grows into adjacent structures, but occludes the lumen of the bile duct. Here, microscopically, you can see this is the bile duct lumen over here. These are these moderately differentiated glands that are basically invading the periductal stroma. That's what makes this invasive adenocarcinoma. Here on a little bit lower power, you can see this invasion better because this is the lumen of the bile duct here, and all this cancer is just moving outwards this way. And when we go on high power, what we see over here is a nerve bundle and some cancer glands around the nerves. And this is what's typically known as the perineural invasion that's unfortunately a common finding in cholangiocarcinoma and tends to be a poor prognostic indicator. So not all hilar tumors are the same. I'll present quickly another patient. This is a 56-year-old gentleman who presented just with pruritus. He had an appropriate workup. He had an elevated CA19-9 of 186 and the appropriate imaging studies that showed this mass. Here you can see this is his contrast-enhanced CT. This is left-sided bile duct dilatation. Coming down, you see this mass over here. And then on the MR, this is a pretty picture here, but this is massive left-sided bile duct dilatation, some moderate bile duct dilatation. This is the gallbladder over here. And again, you have to kind of use your imagination. This is where the cancer is, where there's no contrast. It's an abrupt cutoff with a distal common bile duct, and you can see the pancreatic duct, and this is the duodenum here. So this patient was taken to the operating room, was found to be unresectable. This was a bismuth 4 lesion, which I described, where both the right and left sides of the ducts were involved, so there's no way to allow for a margin negative resection in this patient. So we weren't going to do him a favor by doing a big operation, so we aborted that case. He had a stent placed to the right hepatic duct. So, well, what are our options right now? You know, most centers, I would say, this is it. You get radiation, you get chemotherapy, you get the best supportive care. But believe it or not, liver transplantation is an option for well-selected patients with locally advanced unresectable cholangiocarcinoma. And the rationale for this is that you can readily achieve a tumor-free margin. You're not in the business of the tumor trying to separate it from other structures. That whole thing is coming out. The whole liver is coming out. You know you're going to get the entire cancer. It treats the underlying parenchymal invasion as well as the underlying liver disease. However, liver transplantation for cholangiocarcinoma till this day is not widely accepted nationally. This is probably based on the early results, again, with dismal outcomes, high rates of recurrence, low rates of survival, which definitely question if we're being good organ shepherds using the organs for these patients. But it wasn't until about a decade ago where the Mayo Clinic put liver transplantation back on the map for the hilar cholangiocarcinomas. They took very early stage but unresectable hilar lesions that were small. They treated them all up front with external beam radiation therapy, gave them chemotherapy, took them to the operating room to make sure that they did not have any lymph node metastasis, which is a bad prognostic indicator, continued them on chemotherapy until they got their liver transplant. Now, 111 patients were enrolled in this study, but only 38 made it to transplant, which is basically in line with what we would expect with the pathology and the tumor biology of this disease. But for the 38 patients that did make it to transplant, this was really pretty impressive. 72% 5-year survival. There's no treatment out there for cholangiocarcinoma that can give you a survival of 72% at 5 years. So this was pretty impressive. We looked at our own experience recently, looking at not only the hilar cholangiocarcinomas, but the intrahepatic cholangiocarcinomas. And again, small numbers, but patients undergoing transplantation had better long-term survival than the patients undergoing resection. So this patient, again, was placed on the protocol, received all the treatments that I described, underwent liver transplantation 2 years after diagnosis. So this was another good selection tool, right? So he stood on our list, and we watched him for some time until he got the appropriate priority to get a transplant. And the fact that he had not metastasized in the 2 years while he was waiting, obviously probably selected for a good patient. But nonetheless, that's what we want. We want the things that are going to select good patients that are going to have good outcomes. This is his explant, the left side of his liver, the right side of his liver. These are the vessels going to either side. Again, you can just see this solid mass just really just involving the hilum, and you can see why this would not be surgically resectable. So I'm going to move on now and just talk about important things that we all see in our practice: resection of colorectal hepatic metastasis. These are much more common cancers that we deal with, and it's probably more common than the primary liver malignancies. Hepatic colorectal metastases definitely represents the prototypical disease where I think there's very convincing evidence that surgical resection has a role. So I'll start with a case. This is a patient of mine, 55-year-old gentleman with a T2 upper rectal adenocarcinoma. that was found on screening colonoscopy. He had an elevated CEA to 125, and unfortunately, his staging CT scan showed a very large right hepatic lobe mass with an additional satellite nodule. He also had 2 small pulmonary nodules, so he didn't go to surgery at first. He received 5 cycles of upfront neoadjuvant FOLFOX with Avastin, which is an anti-VEGF agent, and demonstrated a significant reduction in the size of his liver metastases, a decrease in the size of his small pulmonary nodules, with a drop in his CEA to 27.5. Shown here is pre-chemo and his post-chemotherapy scans. You can see this is the cancer. It's huge. It's taking up the entire right side of the liver. It's shrunk over here on this side. Again, bigger, smaller, and this is a coronal slices up and down. You can see how big it was over here, and it's shrunk. Obviously, it's still taking up a big part of that liver. So do we offer this patient resection? Well, why not only chemotherapy? This was a very large study coming out of the MD Anderson Cancer Center, 2,750 patients with metastatic colorectal cancer studied over about 13 years. This study obviously selected for patients that the clinicians taking care of didn't think would benefit from any additional surgery or interventional procedures, but the 5-year survival was poor, 11%, and only 6 patients were alive at 10 years. Not too surprising. However, now there's multiple large studies with thousands of patients that showed that in properly selected patients, that liver resection of the metastases leads to much better 5-year survival, 30 to 50%. And surgery is actually the only treatment for colorectal hepatic metastases that's been shown to basically be associated with a survival plateau, and I'll get to that, which basically means that we're curing some of these patients of their metastatic disease. So how do we work up somebody with a suspected liver metastasis? As I mentioned, the first and most important thing is to rule out extrahepatic distant spread. This is done with an abdominopelvic or gadolinium-enhanced MRI and a chest CT. A lot of people are using a whole-body PET CT, and that's a great test. It's just the added value of a whole-body PET CT was recently thrown into question on the basis of a large randomized controlled trial published in JAMA that basically said it didn't really make a difference in your surgical management, so it was unclear whether there was any reason to order whole-body PET CT in all of them. Regardless of the modality we use, the important thing is to evaluate the number and the location of the metastatic lesions, address whether all the hepatic disease can actually be addressed in one way, shape, or form, and get an assessment of how much liver we're going to leave behind and if that's acceptable. So in the year 2015, I made this slide here just to dispel some of the myths regarding the resection of hepatic colorectal metastasis. So it was traditionally thought that if you had more than 4 metastatic lesions in the liver, or if they were bilobar, that those patients were not candidates. We now routinely resect multiple bilobar metastatic lesions using a combination, again, of chemotherapy and staged resections and ablations. It was thought that a metastatic lesion can't be greater than 5 centimeters in size. We don't have an upper limit to the size of a lesion that we can resect nowadays, as long as it's a safe resection. The presence of extrahepatic disease was absolute contraindication. And now, again, more studies coming out. If you have few pulmonary metastases, they can also be resected and or ablated with reasonable outcomes. It was thought that we needed very big resection margins. Recent studies showed that even a 1 millimeter cancer-free margin is just as curative. Where there were concerns about how much liver we're leaving behind, we now have preoperative portal vein embolization, which I described early on. It was also thought that we should resect all the macroscopic disease. Well, we know we can achieve no evidence of disease with a combination of resections and ablations. You take somebody to the operating room, you can resect a big 8-centimeter tumor on the left lobe, but if they have a 1 small centimeter tumor in the center of the right lobe, you're not going to try to go after that. You can ablate it and actually get a very good result, especially for the smaller lesions that are deep in the liver. It might not make sense to take a whole big chunk of liver out just to get after a 1 centimeter lesion. And finally, the presence of vascular involvement or the portal lymph node metastases were thought to be absolute contraindications. And again, in well-selected patients, not everybody, you can't consider vascular resection with reconstruction. And in the absence of celiac nodes, you can resect their portal lymph node metastases with some improved survival. So a word about the timing of systemic therapy and surgery. For patients who present with synchronous colorectal metastases, I think most people would agree that neoadjuvant chemotherapy up front is important to evaluate the patient's tumor's behavior. Patients that are progressing on systemic therapy are obviously not going to benefit from surgical resection. Having said that, for patients whose primary tumor needs to be dealt with relatively urgently, they have an obstructing colon lesion and something hanging off the left lobe, as long as it's a limited liver resection, I don't think it would be unreasonable to address them both in the same setting, as long as the surgeon felt comfortable doing that. However, for patients with initially resectable metachronous colorectal metastases, meaning the primary has been taken care of, and then sometime in follow-up they develop a new lesion in the liver, the benefit of neoadjuvant chemotherapy in this setting is a little bit less clear. This is based on a large randomized controlled trial in Europe that showed that patients who received 6 months of upfront chemotherapy prior to resection did seem to have fewer non-therapeutic laparotomies, meaning the surgeon didn't go in and say, okay, backed out, but they had more perioperative complications and really a questionable improvement in their progression-free survival. So it's not clear that every patient should get upfront chemotherapy in these settings. However, for patients who are deemed to be unresectable at the time that their liver metastases shows up, there's no question that upfront chemotherapy can increase the resectability rates for these patients. So can we cure metastatic disease? This is contentious, I understand that, but I'll show you some data. This was a study out of the Memorial Sloan Kettering Cancer Center, probably arguably the biggest cancer center that does these operations. It was an analysis of 612 resected colorectal liver-only metastases with actual 10-year follow-up. And they showed that while 34% of the 5-year survivors went on to suffer a cancer-specific death, that actually only one of the 102 actual 10-year survivors ever suffered a disease-specific death. So basically what they've defined is they've said, if you've survived 5 years after resection of your liver metastases, you're not totally in the clear. A third of those patients still go on to develop new lesions or die of their disease. But if you're 10 years clear, you're basically cured. So this is probably the best data that's out there, and I think most people do believe that if you're out 10 years from resection of a metastatic lesion to your liver from colorectal cancer, you're probably cured. So back to our patient. Hopefully I've shown some data to at least support trying to be aggressive and resecting this patient. We did do, this is what the volumetrics look like that I described, and after his chemotherapy, even though he had a very good response, his future liver remnant was 31%. It wasn't below the absolute minimum, but given all the chemotherapy he had had to get him here, I didn't feel comfortable with that. So we had our interventional radiology colleagues perform a portal vein embolization. He had a significant growth of the left lobe of his liver. You can see, I think the volume, I can't read that, it's about 800 from 500 or 400, so his future liver remnant now was 46%. We all felt more comfortable with that, took him to the operating room. This is a right hepatic lobectomy. This is the huge tumor here, pathologic specimen. This is the big one and the small satellite nodule next to it. The margins were negative, and here's the microscopic pictures. You can see these particles over here are probably the embolization coils from his prior procedure. The majority of the mass over here is just necrotic, as you can see, and there was viable carcinoma, but he had had a very good response to his chemotherapy. So in the next 5 or 10 minutes or so, I'm just going to focus on the metastatic neuroendocrine tumors. These are much rare tumors. I mean, we don't always come across these tumors. Their incidence is 1 to 2 per 100,000 compared to 40 to 70 per 100,000 of colorectal cancer. And the classification of neuroendocrine tumors is really quite confusing. It's gone through multiple iterations and naming schemes over the last 10 years, but suffice it to say that patients that stand to benefit from resecting their liver metastases are those that have the well-differentiated tumors, the low grade 1 or grade 2 lesions. The mitotic count is very important. It's got to be a low mitotic count. And the nuclear proliferative index, which is a immunostain, Ki67 is what it's called, that needs to be less than 20%. These are traditionally the tumors that were called the intestinal carcinoids, the islet cell tumors, the pancreatic neuroendocrine tumors, and they actually can be resected, and I'll show you some data. However, for patients who have poorly differentiated grade 3, high-grade lesions, high mitotic counts, high Ki67 indices, these patients are going to do poorly no matter what we do, and we don't typically take them to the operating room. You're not going to help them. So metastases from primary neuroendocrine tumors to the liver most commonly arise from tumors of the pancreas, as shown here. This is a specimen of the pancreas and spleen taken out with an incidence of about 60%, and intestinal carcinoid tumors with an incidence of 30 to 85%. This is not too surprising. Why do these lesions metastasize to the liver? Well, if you take into consideration how they drain, the pancreas drains through the splenic vein and superior mesenteric vein into the liver, as does the intestinal portal venous drainage, and that's why they develop liver metastases. The options for metastatic neuroendocrine tumors include liver resection, cytoreductive therapy, and liver transplantation. I'll very quickly go through all of them. This slide summarizes some of the largest series, which again, there's not too many patients because this is a rare disease, but in the larger series, patients who have low-grade indolent disease really have pretty good long-term survival and better than patients who did not undergo resection. However, recurrence after resection of metastatic neuroendocrine tumors seem to be the rule rather than the exception, with slightly less recurrence for the intestinal carcinoids compared to the pancreatic primaries, and definitely less recurrence after a complete resection than an incomplete resection. That's not too surprising. Again, not surprising, Ki-67 is an important prognostic indicator with very reasonable long-term survival for those with a Ki-67 index of less than 20%, and you can see how this curve just drops off immediately. Patients who have resection of tumors that have a very high proliferative index, they just continue to grow after resection and they don't do well. So based on this data, contraindications to taking these patients to the operating room include diffuse liver metastases, extrahepatic tumor involvement, carcinomatosis in the abdomen, and the poorly differentiated tumors with high Ki-67 indices. Cytoreduction is a little bit controversial. You can certainly consider them, especially in the patients that have the neurohormonally active tumors that really, they become very, very symptomatic. So if they have a neurohormonally active tumor, but that's otherwise behaving well with a low proliferative index, and you feel you can address the majority of the lesions either by cutting them out or ablating them, you can take them to the operating room. This is not a curative procedure, but it can certainly improve the quality of life for these patients. And finally, again, lots of data showing liver transplantation to be a viable option for a subset of these patients with 50 to 90% long-term survival after liver transplantation. Not surprisingly, the same prognostic factors apply here. What's important after liver transplantation? Patients with a low Ki-67 index, again, do much, much better than those with a higher Ki-67 index. If you have an intestinal primary versus a pancreatic primary, you tend to do better. And also, if your liver is not too enlarged, which basically is a surrogate for how much tumor is infiltrating the liver. And finally, wait time. These are, generally speaking, neuroendocrine tumors are very indolent tumors. Some people are alive with them for years and years and years, and so there's no reason to really rush these people off to the operating room for a transplant if they have metastatic disease. You want to watch the natural history of the tumor. You want to see what the tumor biology is. And so as you can see, the longer the wait list time, the higher the mean survival after transplant, probably because you've allowed the tumor biology to declare itself and better selected for your patients. So based on this data, again, the indications for liver transplantation for metastatic neuroendocrine tumors include those unresectable tumors that are well differentiated, WHO grade 1 or 2, with low mitotic indices, low Ki-67 indices, whose portal venous drainage is primarily to the liver, and who have demonstrated some stable tumor disease, and again, contraindicated in patients with extrahepatic disease, poor differentiation, high Ki-67 index. So I'm going to stop there. In summary, surgical therapy for liver malignancies is now much safer. Resection and liver transplantation are very important modalities for patients with primary liver malignancies, and there's now an increasing role as the systemic therapy gets better of surgery for patients with metastatic disease, in particular colorectal and metastatic neuroendocrine tumors. So I thank you for your attention.
Questions? If you have a question, raise your hand and we'll get you the microphone.
This is a very complex subject. As primary care, I don't think I've ever ordered a CA 19/9.
Yeah.
What is our role? I mean, should we try to work something up, or should we just, as soon as we have indication, we just plug them into your program?
I think that's an excellent topic.
And where do we participate long term?
I think it's the recognition from the primary care of what are the symptoms. And like I said, I mean, that's what I was kind of drawing the attention to. I think the important thing is, if I just take a step back, I showed you all this data, but if I take a step back, I think the important things to recognize is fatty liver disease. You got to worry about whether they have underlying cirrhosis. If there's any concern about that, you absolutely have a role in screening these patients with ultrasounds and AFPs, you can do that. It depends on what you're comfortable with, or perhaps a gastroenterologist is going to follow that patient. Same with cholangiocarcinoma. I agree, at some point, you're not going to continue on with the workup and ordering all the scans and all that stuff, but I think it's the recognition of what are the basic symptoms these patients are presenting with. Pruritus, sclera icterus, these kinds of things. You got to worry, painless jaundice. These are the kinds of things that you have to raise your level of suspicion that there's something going on. Right. I think it is very difficult. I agree with you 100%. I think in that setting, for example, I think the important thing is to not to lose the patient, right? So if a patient's coming to you in urgent care with pruritus, there could be a million other things that are causing pruritus. You're not going to jump to cholangiocarcinoma, but I think the important thing would be to make sure the patient's plugged into the system. You make an assessment of what you think this is, the most common things, you treat them. If they don't get better, if the problem is still there, I think the role is to make sure that they're still plugged into a system so they're not lost and they don't show up 7 months later, with a bilirubin of 15 and now it's already too late. So your point is very well taken.